Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just want to go over a few housekeeping items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located above your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to Dr. Emily Lau. She is a cardiologist at Mass General, affiliated with the Oregon Women's Heart Health Program and an instructor of medicine at Harvard Medical School. She is also a scientist whose research focuses on understanding how differences between men and women contribute to heart disease. In recognition of American Heart Month and Go Red for Women, which was a couple of weeks ago, she joins us today to give a talk on sex differences in heart disease and unique risk factors in women. So please join me in welcoming Dr. Lau.
So much for that very kind introduction. Are you able to see my slides? Excellent. Well, thank you all so much for joining me today. I am delighted to be here today on Valentine's Day of all days to talk about a topic that is near and dear to my heart, no pun intended, sex and gender differences in heart disease and unique risk factors in women. I'm supported by a grant from the American Heart Association and have no other relationships to disclose. Before we get started, I'd like to start with a little bit of vocabulary. When we talk about differences between men and women, we often hear the words sex and gender tossed around. So what's the difference? Well, sex refers to biologic differences that are related to sex chromosomes and sex hormones, while gender relates to differences related to environmental, social, and cultural factors related to being male or female. Often it's very difficult to clearly disentangle sex and gender. So for the purposes of today's talk, I'll be using sex as shorthand for sex and gender for clarity's sake. Here's the roadmap for today's talk. First, I will review sex differences in heart disease and sex-specific risk factors for heart disease in women. And then I will review strategies to prevent heart disease for women. And finally, I'll talk about hormones and heart disease risk. So let's get started. As many of you are aware, heart disease is the leading killer of women and men in the United States and worldwide. But awareness that heart disease is the #1 cause of death in women is actually declining. These are data from an American Heart Association survey that asked women to identify what they thought was the leading cause of death among women. And you can see here in 2009, only about 2/3 of women were able to correctly identify heart disease. But perhaps what's more sobering is 10 years later in 2019, awareness had significantly declined. Only 44% of women were able to correctly identify heart disease as the #1 cause of death in women. So we have a lot of work to do, and that is why I'm so glad that you're all here with me today. So let me give us all a framework and vocabulary to use for the rest of the talk. At the simplest level, the heart is a muscle. It pumps blood throughout the body. And it takes deoxygenated blood from the body, delivers it to the lungs so that the blood can become oxygenated. Then it takes the oxygenated blood from the lungs and delivers it to the rest of the body. If we take this to the next level of complexity, I like to break up the heart into 4 major components. #1, the pump or the muscle. #2, the coronary arteries or the arteries that supply the heart muscle. 3, the valves, which are basically like doors that connect the different chambers of the heart. And 4, the rhythm. The heart actually has a sophisticated electrical system as well. This framework helps me and other cardiologists think about the different types of heart disease that a person can have. For example, a failure of the pump function or muscle function of the heart is called heart failure. And patients with heart failure or problems with the pump can no longer deliver oxygen effectively to their vital organs in the body, and blood and fluid will back up from the heart to the lungs. Problems with the arteries of the heart are called coronary artery disease. The most dramatic consequence of coronary artery disease is a heart attack or a myocardial infarction, when part of the heart muscle actually dies because there's not enough oxygen being delivered to the heart due to a blockage in the arteries that supply the heart. Similarly, patients can have problems with the valves and/or rhythm issues. There are actually differences between men and women for each of these four components. For today, I'm going to spend my time discussing sex differences in coronary artery disease, or CAD, and heart failure, or issues with the heart muscle or pump. CAD is the most common form of heart disease. It includes heart attacks and chronic chest pain, otherwise known as angina. And some of the risk factors include smoking, obesity, high blood pressure, and diabetes. There are significant differences in the epidemiology of CAD between men and women. First, on average, women develop CAD 7 to 10 years later than men. Second, risk factors such as smoking or hypertension predispose women to a greater risk of heart disease than men. Third, while most cases of CAD come from cholesterol buildup in the coronary arteries, otherwise known as atherosclerosis, there are some unique causes of CAD, including spontaneous coronary artery dissection or broken heart syndrome. These unique causes are much more common among women. And finally, women are more likely to experience disease in the small coronary arteries rather than the large coronary arteries, also known as microvascular dysfunction. Well, what about how CAD presents? Does CAD present differently in men and women? And the short answer is sometimes. Chest pain is the most common presenting symptom of a heart attack in both men and women. But women are more likely than men to experience other symptoms besides chest pain, like upper body pain, nausea, lightheadedness, shortness of breath, sweating, or fatigue. What about treatment? There are a number of medications that have been shown to reduce the future risk of coronary disease among individuals who have been diagnosed with CAD. These medications include aspirin, cholesterol medications like statins, or beta blockers. Now, these treatments are shown to be effective in both men and women. And yet, women with CAD are less likely than men to receive guideline-directed medications and therapy to reduce their future risk of CAD. This is why it is so important that patients and doctors alike recognize that heart disease is not just a man's disease. Next, I'd like to briefly touch upon sex differences in heart failure. Heart failure, remember, is a condition where the heart muscle has an issue and doesn't pump as well. And heart failure is quickly becoming one of the most common conditions in the United States. And there are clear differences between men and women with heart failure. In general, women are more likely to develop a form of heart failure called heart failure with preserved ejection fraction, where the heart muscle is stiff and does not relax well. Men, on the other hand, are more likely to develop a form of heart failure called heart failure with reduced ejection fraction, where the heart muscle is weak and does not pump well. Now that we've briefly introduced an overview of how heart disease can differ between men and women, I'd like to review risk factors for heart disease that are unique to women. So we are beginning to recognize that pregnancy is an important window into a woman's future risk of heart disease. Adverse pregnancy outcomes like hypertensive disorders of pregnancy, gestational diabetes, and preterm birth have all been shown to increase the risk of coronary artery disease and stroke up to 1.5 to 2 times. These are data that from one of my colleagues and friends here at MGH, Dr. Michael Honenberg, and he found in a large sample from the UK that a history of hypertensive disorders of pregnancy accelerate cardiovascular aging and increase a woman's risk of developing CAD, heart failure, and valve disease. Beyond the reproductive years into the midlife, risk of heart disease in women accelerates after the onset of menopause. And what we've found is that women who undergo menopause at an earlier age than average actually have a higher risk of developing heart disease later in life. This is true for women who undergo menopause naturally, as well as for women who undergo surgical menopause, either via hysterectomy and or oophorectomy. Recently, I and colleagues have found that infertility is another reproductive risk factor that is associated with increased risk of heart failure among women enrolled in the Women's Health Initiative. So what can a woman do to prevent her risk of developing heart disease? So let me take you through a typical preventive cardiology clinic visit. When I see a patient in the clinic who asks me what they can do to prevent heart disease, I first ask them a number of questions about the risk factors, like age, sex, race, ethnicity, blood pressure, cholesterol, diabetes, and smoking. While we can't change our age, sex, or race ethnicity, we can change a number of other factors like our blood pressure, cholesterol, diabetes, smoking, etc. Then, based on how many risk factors my patient carries, I classify them as low, intermediate, or high risk for developing heart disease. For low risk patients, we recommend lifestyle changes like a heart-healthy diet and exercise. For our intermediate risk patients, we begin thinking about medications like blood pressure lowering medications or cholesterol medications. And for our high risk patients, we emphasize both. So far, I've spoken about traditional risk factors, and that means risk factors that we have known are connected to heart disease for some time now. But there are some other clues for assessing heart disease risk that are beyond the traditional risk factors. And these are some of these clues. A family history of heart disease, early heart disease in particular. That might be a clue to a genetic risk. Metabolic syndrome, kidney disease, a special type of cholesterol called lipoprotein A, elevated inflammation, and autoimmune diseases. And as we discussed earlier, adverse pregnancy outcomes and early menopause are both risk-enhancing factors as well. So finally, after assessing all of the patient's risk factors, her clues and risk-enhancing factors, I counsel her on the following. Make sure to adopt a heart-healthy diet. The Mediterranean and DASH diets are supported by research. Minimize saturated and trans fats, eat more vegetables. Regular exercise is incredibly important. We recommend about 30 minutes of moderate intensity exercise at least 5 times a week. Maintain a normal weight. Avoid smoking, moderate alcohol intake. Get regular medical care with routine screening for heart risk factors as appropriate for one's age. And then depending on your risk factors, preventive medications may be appropriate. And finally, ensure that your doctor knows your pregnancy and menopause histories. For the final part of my talk, I'm going to segue into discussing hormone therapy in heart disease. This is a topic that has been and continues to be a hot area of debate for decades. The history of modern-day menopausal hormone therapy in the United States began during the Great Depression when Premarin, which is a conjugated estrogen that we actually extract from the urine of pregnant horses, emerged on the market for the treatment of hot flashes and other vasomotor symptoms in postmenopausal women. So after it was introduced, prescriptions for Premarin quickly rose over the next few decades. Because as you can imagine, hot flashes and vasomotor symptoms are a huge issue for postmenopausal women. However, in 1975, several studies demonstrated that there was an increased risk of endometrial cancer with unopposed estrogen therapy. So this led to a significant decline in hormone therapy use. But by the early 1980s, scientists and doctors were able to recognize that adding progesterone to estrogen actually reduced this endometrial cancer risk. And therefore, combination estrogen and progesterone therapy was developed. And this is how the formulation in which hormone therapy is delivered today. And this really brought about a revival of menopausal hormone therapy in the US. In the 1990s, observational data from the Nurses' Health Study and others found that estrogen therapy was significantly associated with the lower risk of cardiovascular disease. These findings actually fueled probably the biggest dramatic increase in menopausal hormone therapy prescriptions. By the late 1990s, over 90 million prescriptions for hormone therapy a year were being given out in the United States. It really seemed like every woman was on hormone therapy at that time. Cracks in the armor began showing up, though, in the late 1990s with the publication of the HERS trial. This was a trial that randomized women who had a diagnosis of coronary artery disease to either receiving combination estrogen and progesterone hormone therapy versus placebo. While women who were randomized to the hormone therapy arm had better cholesterol profiles, there was actually an increase in coronary artery disease events in 1 year, and then overall, the results were neutral at 4 years. So after the publication of the HERS trial, we saw a slight reduction in hormone replacement therapy prescriptions. But the nail in the coffin really occurred in 2002 with the publication of the Women's Health Initiative. This was a randomized trial of combination estrogen and progesterone in postmenopausal women who did not have any history of heart disease. And the study was terminated early because they saw an increased risk of breast cancer. Then when they looked further, they also saw an increased risk of coronary artery disease, stroke, and blood clots in the lungs. Hormone therapy prescriptions plummeted. Since the primary WHI results, subsequent analyses have suggested that maybe the story is a little bit more nuanced. Investigators went back and looked at the WHI results again, and a new hypothesis called the timing hypothesis emerged. And this hypothesis suggests that the cardiovascular effects of hormone therapy might actually depend on when you give hormone therapy, when you start hormone therapy in relation to a woman's age and how long they have been in menopause. The KEEPS and ELITE trials were published in 2014 and 2016, respectively, and they were both trials that looked at estrogen and progesterone therapy based on timing. And what they found was that coronary artery atherosclerosis decreased with hormone therapy in women early postmenopause. So how do we think about hormone therapy after that roller coaster? Well, we think of it this way. First, hormone therapy is really only used for the treatment of postmenopausal women with moderate to severe vasomotor symptoms. And we do not use hormone therapy for the prevention of coronary artery disease like we used to think was true. For women who are less than 60 years old or less than 10 years postmenopause, there are no contraindications. However, for women who are older than 60 and at least 10 years postmenopause, we estimate their coronary artery disease risk before prescribing. And if we find that their 10-year risk is low to intermediate, we think about prescribing transdermal estrogen formulations or, of course, non-hormonal therapies. If a woman's risk is high, we really recommend non-hormonal therapies as the choice. A few other tips we think about. We try to use the least effective dose for the shortest time possible. We attempt to taper the hormone therapy after 3 to 5 years. We avoid using hormone therapy really beyond the age of 60 to 65. And if a woman has had a hysterectomy, you don't need the progesterone, you can use estrogen alone. So what did we discuss today? Well, we first reviewed sex differences in heart disease and highlighted the importance of understanding that heart disease is the leading cause of death in both men and women alike. We also discussed sex-specific risk factors for heart disease in women. This includes adverse pregnancy outcomes and early menopause. We reviewed how to prevent heart disease in women. Particularly, we really want to make sure that your doctor knows your pregnancy and menopause histories in order to refine his or her assessment of your heart risk. And finally, we ended with sort of a review of the history of hormone therapy and heart disease risk. Finally, I just want to thank my colleagues here at the Corrigan Women's Heart Health Program. We are so lucky here at MGH to have one of the few women's heart health centers in the world. And I'd be happy to take any questions at this time. Thank you.
Sorry, I didn't realize I was on mute. We are now towards the end of the session. If you have any questions for Dr. Lau, please enter them in the chat box. So we have a question from an audience member. What exactly causes nausea? Is it the pyruvic acid that's released from sloughed off myocardial cells or something else?
That's a really great question. And it's, I think nausea from heart attacks really come from a number of different places. It's not related necessarily to sloughed off myocardial cells, but really activation of our vagus nerve, activation of centers that create nausea. It's still uncertain as to why women are more likely than men to experience nausea during a heart attack, but that's obviously an area of active investigation.
Thank you. Why does a woman with a hysterectomy possibly only need estrogen and not progesterone?
Excellent question. So as I was showing in the timeline, in the 1970s, we discovered that if you give estrogen alone to women who still have their uteruses, there actually is an increased risk of endometrial cancer. But if you've had a hysterectomy, you no longer have a uterus, you no longer have a risk of endometrial cancer. So you only need the estrogen, you no longer need the progesterone.
Thank you so much. Do you think calcium scores are useful and helpful in heart disease for women?
Calcium scores are a really great technology. They are used specifically in individuals who do not have a diagnosis of coronary artery disease, and I think it can be a very helpful tool for prevention. In particular, if you haven't been diagnosed with coronary artery disease in the past, and you don't know, and you want to get a sense of what your risk is for developing a coronary event in the future, a coronary artery calcium score can give you a sense of the burden of atherosclerosis that you already have.
Thank you. What are some non-medication approaches do you recommend to reduce arterial plaque?
I think all of the approaches that I outlined in terms of how can we reduce a woman's risk of heart disease are really important. So a DASH or Mediterranean diet, eating a heart healthy diet is incredibly important. Regular exercise, definitely quitting smoking if you smoke, moderating your alcohol consumption, maintaining a normal weight. These are all important lifestyle modifications that I recommend to all of my patients.
Thank you. What is the health risk of using Premarin cream after menopause?
Right, so Premarin cream is what we consider a transdermal formulation of hormone therapy. And we really think about the risk of cardiovascular events with hormone therapy based on a woman's age and how far they are away from menopause. So as I mentioned sort of in the last part of my talk, if you're under 60 years of age and have just undergone menopause within the last 10 years, there's really no contraindication to using transdermal or systemic hormone therapy. In women who are older and have been out of menopause for some time, but have a low to intermediate cardiovascular risk, I think transdermal Premarin is still a very reasonable option. Now, for individuals who are really high risk, I probably would try to avoid using any hormone therapy formulation, really because of the risk of coronary artery disease events that we saw with the publication of the WHI study.
Thank you. After a complete hysterectomy, if you just take the estrogen, would it affect any chemotherapy?
So I'm not an oncologist, and it really depends. It depends a little bit on what the chemotherapeutic agent that your oncologist is thinking about prescribing. So in that scenario, I think I would recommend sort of a shared discussion between your cardiologist, your endocrinologist, your oncologist and your primary care physician.
Thank you. How do you assess the amount and type of plaque and the associated risk?
So, I think it depends. The only way to truly know how much plaque somebody has is to actually perform an imaging study. So somebody had asked the question about coronary artery calcium score earlier. That's an assessment of how much coronary calcium, which is a proxy for plaque, somebody has, and you can do that through a CAT scan. We have more refined imaging tools like a coronary artery CT angiography, which actually can help you delineate what plaque is available. And then, of course, the most invasive but most definitive diagnosis for coronary artery plaque is through what we call invasive coronary angiography. Now, these tests we do not recommend on every single person, particularly if they're healthy and do not have symptoms. Probably the only test I would recommend for prevention for somebody who does not have symptoms, does not have a known history of coronary disease would be a coronary artery calcium score. The other tests are really used to help us define whether or not somebody's symptoms, if they come in with chest pain, for example, are those symptoms related to coronary artery plaque? Then we might think about getting a coronary artery CTA, or think about a stress test, or think about even going to a cath or otherwise known as invasive coronary angiography.
Thank you. So we have another question about hormone replacement therapy. If you've been on hormone replacement therapy for 3 years, is one slowly taken off the therapy or a blood stop? And what types of side effects, if any, are experienced once hormone replacement therapy is stopped?
So I think the real question centers on how bad your hot flashes or vasomotor symptoms are. For women, some women have really intolerable hot flashes, and the only way to, be able to try to mitigate those symptoms is through hormone therapy. In those scenarios, I definitely recommend more of a taper rather than bluntly stopping. Now, if somebody's symptoms were quite mild, you might think about coming off of it and seeing, but that, again, it really depends on the nature and severity of a woman's symptoms.
Thank you. What are some causes of heart failure? How can we prevent it? What exercise make a heart stronger?
That is a great question. We need a whole nother talk to talk about heart failure specifically. There are numerous causes of heart failure, but I would just highlight a few, the most important ones. Coronary artery disease is still by far the most common cause of heart failure, but we're beginning to recognize that other risk factors like high blood pressure, obesity, diabetes may predispose to an individual's chance of developing heart failure. And as I alluded to earlier in my talk, there are 2 types of heart failure with reduced ejection fraction, where the heart muscle doesn't squeeze as well, and heart failure with preserved ejection fraction, where the muscle is stiff and doesn't relax as well. And the causes of these 2 different types of heart failure vary. In general, what can we do to make our heart stronger? Well, heart is a muscle, just like any other muscle. You need to continue to work to use it in order to keep it healthy. So how do we use our hearts? Well, that's through regular exercise, aerobic exercise specifically. So walking, running, cycling, swimming, those types of exercises are really helpful for maintaining a healthy heart.
Thank you. When should someone see a cardiologist?
So we, as cardiologists, we love seeing, one of the fun parts of being a cardiologist is that we take care of individuals who actually don't even have a diagnosis of heart disease yet, but they're interested in trying to prevent the development of heart disease, all the way to, a patient whose heart is failing and needs a heart transplant. Depending on where you are in the spectrum, we can refer you to different types of cardiologists. If you don't have a history of heart disease, but are interested in understanding your overall risk and how to prevent future heart disease, I'd recommend that you see one of our preventive cardiologists. If you have symptoms of heart disease or have known heart disease, you can see one of our general cardiologists. And then obviously based on the type of heart issue, then we have more specialized cardiologists, including doctors who, electrophysiologists who focus on the heart rhythm issues. We have heart failure doctors. We have interventional cardiologists who actually perform procedures to open up plaques in the arteries. So it really depends on your specific overall health status.
Thank you. If someone doesn't have a cardiologist, which doctor would be willing to order a coronary artery calcium score? Does it have to be a heart specialist, a primary care physician?
There are some primary care physicians who are very savvy and who are particularly interested in prevention of cardiac diseases. And so they may be comfortable ordering a coronary artery calcium score or coronary artery calcium scan. But generally, I would recommend for primary care physicians who are not as comfortable ordering these tests that you meet with a preventive cardiologist or a general cardiologist.
Thank you. We have another question about testing. How often should you have a stress test or calcium score? How quickly can plaque build up even after a previous good test result?
Got it. So the question is, how quickly can plaque build up after you've had a stress test that was normal or a coronary artery calcium scan that was normal? The progression of plaque does take over years to develop, but sometimes what we're beginning to realize is that there are different types of coronary artery plaques, that they're not all made equal. The ones that we're able to detect easily are the ones that become calcified or actually protrude into this lumen or into the space of the artery. But sometimes there are plaques that actually build underneath the surface, and those can cause issues without us ever knowing. But I would say in general, to answer that question, it usually takes years for coronary artery plaques to progress.
Thank you. How do you know which doctors are general cardiologists?
So you can, if for example, you're here at Mass General Hospital, you can call our heart center and ask that you would like to be referred to a general cardiologist. General cardiologists are individuals who actually, they don't do procedures and they are not specialized in heart failure or heart rhythm issues. And I'm a general cardiologist and most of us are also general cardiologists. So you just call up the heart center and we can point you in the right direction. But all of us have been trained in general cardiology, even if we end up specializing later.
Thank you. Would you be able to spend a few minutes to talk a little bit more about coronary microvascular dysfunction, ischemia with no obstructive coronary arteries, and myocardial infarction with non-obstructive coronary arteries?
Excellent. I love that, people are recognizing the lingo now. We have come to realize that coronary artery disease extends beyond the big arteries. And those, in the past, we always knew that we have 3 big coronary arteries. And when we put a stent in a patient, for example, it's because there was a blockage in one of the big arteries. But particularly among women, we're realizing that many women actually experience heart issues because they have disease in the small arteries. And that's what we call microvascular dysfunction. And it can, disease in the small arteries, microvascular dysfunction can lead to a lot of issues. It can lead to chest discomfort. It can even cause myocardial or heart injury. So it's not something to be taken lightly. but we're really only now beginning to understand how to recognize it, diagnose it, and treat it. And along this same spectrum, MI with non-obstructive coronary arteries is a phenomenon where you actually have injury of the heart muscle without visible plaques in the big arteries. And often it's thought to be related to conditions like microvascular dysfunction. And by and large, they can happen in both men and women, but they are just far, far more common among women patients.
Thank you. In Heart Center's experience at Mass General, as well as any previous research you've come across, have any patients succeeded in reducing arterial plaque without needing medications or surgery?
I think it depends on how severe the plaque is and the scenario. So if we find, in general, with healthy diets and exercise, I do think that you can regress coronary plaque. But if it becomes severe enough, it often becomes very challenging to do without at least some pharmacologic therapy, if not intervention. But it really depends on the severity of the plaque and also the symptoms that the patient is experiencing.
Thank you. So while we wait to see if there are any final questions, Dr. Lau, any final thoughts you'd like to share with the audience?
I'm just so thrilled that so many of you joined us today. This is such an important issue. It's really amazing in 2022 that women's heart disease is still really under-recognized, and it's something that we're really passionate about trying to we're really passionate about trying to spread the word that this is something that women need to be aware of. Men need to be aware that women's heart issues are also important. So I'm just so thrilled that you're all here with us today.
Thank you. So we do have a question about surface plaque. What causes the below surface plaque you mentioned versus the hardening, more visible type?
It's a great question. It's an area of active investigation. We don't yet know what causes some plaques to be what we call soft plaque versus those that become calcified. But it is more common among women to have sort of this soft plaque. And it is actually, we have investigators here at MGH who are actively looking at this question.
Thank you so much. All right, so I don't see any further questions. And we'll give it another minute. While we do that, did want to mention, as I had discussed, the session is being recorded. So if you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. All right, so I think today concludes today's session. Thank you so much, Dr. Lau, for a wonderful session. Have a lovely rest of the day.
Thanks, everyone.